All right, so I'm Addie Patterson. I am a movement disorders neurologist here at the UF Fixed Cell Institute for Neurological Disease. I welcome everyone. I'm so glad you could put some time aside on your Saturday to join us. The topic of my presentation today is differences in the approach to care for patients with advanced Parkinson's. So it's a little bit different than the phraseology of advanced care planning. I know that is a session that we held last year. That's kind of more about planning your advanced directives, but the topic for today's session is really how do we approach treatment in people with advanced Parkinson's as compared to people in the early stages of Parkinson's. Concurrently with this session, my colleague Pavna Patel is presenting a session on sexuality and Parkinson's. And so for those of you who have opted to join this session live, that's great, thank you. But I think she also has some really wonderful information that will eventually make it to our website and our YouTube channel if you want to catch that after the fact. So we'll go ahead and get started. So I have no disclosures for my talk today. We will go through what are the stages of Parkinson's. So how do I even know if I have advanced Parkinson's? What stage am I in at this time and what do I have to look forward to? What are the categories of Parkinson's symptoms? What are common problems in advanced Parkinson's? How does the approach to medications and treatment change in the setting of advanced Parkinson's? And we will review a holistic care philosophy that can be employed at any time in Parkinson's, but especially in advanced PD. So what stage am I? So I like this graphic because it's visually appealing, but in truth, Parkinson's is not a linear path. It's not a road. There's not a road map. It's not necessarily that you'll pass the blue marker, then the red marker, then the orange, then the purple. Everyone's different. You may start at orange, then develop red next, and then end up at purple. Everyone's different. It's not linear. But in general, this is kind of how we approach stages of Parkinson's. So this video I will pull up. It is a video that's actually produced by the Parkinson's Foundation, and you'll hear Dr. Jankovic's voice in the background. He's a world-renowned Parkinson's specialist, and it kind of outlines the stages of Parkinson's for us.
Speaking of stages of the disease, we divide the natural course of progression of Parkinson's disease into the 5 stages, the so-called Hone and Yar stages, where stage 1 represents chiefly unilateral, one-sided symptoms such as tremor. Stage 2 means that the symptoms occur bilaterally on both sides. Stage 3 means that the patient is beginning to develop some difficulties with their balance, but still are able to ambulate without assistance. Stage 4 means they require assistance with ambulation, and stage 5 usually means that the patients are wheelchair bound or bedridden. So these are the 5 stages of Parkinson's disease, and our goal, of course, is to maintain the patient in the earliest stages of the disease as possible with appropriate treatment.
So I like that video because it walks us through the stages of Parkinson's that your physician will use. It's the Hone and Yar stages 1 through 5. But this has limitations. You know, what we heard about in that video was only related to motor symptoms. And, you know, Parkinson's, for those of you living with it and for those of us taking care of people with Parkinson's, we know that Parkinson's is not a pure motor disease. So it's possible to have unilateral symptoms, maybe a tremor just on one side, but many, many more symptoms that would make everyone say that you are not in the early stages of Parkinson's. So it's not, so Parkinson's is more than just motor. But for the purposes of kind of classical staging, you know, stages 4 and 5 are considered advanced Parkinson's. So I wanted to put this slide back up just because I know the video goes through it quickly and you may not have, I don't know how the sound quality was, but in general, so stage 4 and 5, we consider advanced Parkinson's. That is when the symptoms become severe and they limit you in your day-to-day life. It may be possible to stand without assistance, but movement may require a walker. A person may start to need help with their daily living, and they're unable to live alone, or you know, they have symptoms even more severe than this, where they're kind of wheelchair bound or bedridden, maybe require nursing care. So these are the stages kind of as defined by motor symptoms. But what I want to do is kind of reframe, because again, we know that Parkinson's is not just a motor disease. So Parkinson's is a motor and a non-motor disease. And like I've titled this slide, this is PD oversimplified. So, but I do think this is helpful, and this is how I tend to explain to my patients. So on one hand, one side of the coin, we have motor symptoms. And so these motor symptoms are caused more or less by dopamine deficiency. So I like this cartoon here because it shows us, at the top, a neuron with a synapse where we have these neurochemicals or these little blue bubbles that are emitting from the neuron. They're landing on the synapse and causing the cause and effect that we want, which is smooth movement that's coordinated and rapid without extra movements. In Parkinson's, our dopaminergic neurons are affected. We don't have enough dopamine, so we can't cause, the downstream consequences that we want. So our motor symptoms are affected, our motor systems are affected. So that's one side of the coin. And that is, often the symptoms that predominate early on. And that's why our staging scale kind of focuses on those symptoms. But certainly those are not the only symptoms of Parkinson's. So we have non-motor symptoms, and those we can think of as being not influenced as much by our dopamine levels. So there's a secondary process that's happening. And in that process, we have alpha-synuclein protein that's depositing throughout our brain. And we call those protein deposits Lewy bodies. So you may have read about that when you read about Parkinson's. This cartoon here at the bottom, we're looking at the red and dark red as areas of the brain that are affected by these proteins or Lewy bodies. And on the leftmost aspect or panel of the cartoon, it shows the red or dark red only in the deep parts of the brainstem. And then as time goes on, they spread further. So they kind of spread up and out. And so early stages of Parkinson's, which are affected by these proteins depositing deep in the brain, the symptoms that can result tend to be less life-altering. So you lose your sense of smell. Okay, mild. You develop constipation. That can be, a mild symptom, or it can be quite problematic, dream enactment. Then as time goes on and the proteins spread up and out to our emotion, cognitive, and thinking areas, people can develop more severe symptoms that impact their day-to-day life much, much more, such as dementia, psychosis, hallucinations, and things like that. So I want to acknowledge that for the purposes of our talk today, we're not just talking motor. We're talking motor and non-motor, and these are the symptoms that we are going to go through today. So I would consider someone with advanced Parkinson's to be really anybody who has any of these symptoms: worsening motor function, limitations in their mobility, complications of the medications that they take for their motor symptoms, psychiatric disorders, cognitive disorders, and then disorders of the automatic nervous system or autonomic disturbances. And we'll kind of go through these. So worsening of motor function and limited mobility are pretty self-explanatory. But when we think about these and why they change as time goes on with Parkinson's, it's helpful to think about that dopamine replacement theory. So dopamine replacement helps certain motor symptoms, but not all. So it tends to help stiffness, slow movements, and some aspects of gait, but it doesn't really help balance, and it doesn't help advanced gait symptoms like freezing of gait, festination, where our center of gravity gets out in front of us and pulls us forwards. So as those symptoms start to increase, they may be less responsive to medication. Drug-induced motor complications. So I have a whole slide about this because I think it's easier to see this kind of in cartoon format here. But so if we think about drug-related motor complications, what is really going on? So our motor symptoms are driven largely by lack of dopamine. When we were first diagnosed with Parkinson's, we still have some dopamine left. We have some of our own natural dopamine floating around in our system, able to bind to those receptors. So we might take a dose of medicine and not really feel a big difference because we still have some of our own dopamine. We have a buffer there. So we take the medicine and overall maybe we feel better, but we don't feel each individual dose kick in or each individual dose wear off. We can't tell if we're an hour late. But as time goes on, we have less of our own dopamine. And so we really we really feel that kicking in and wearing off. So that's the first box here on the right. Noticing off and on stage states with each dose, which your doctor might call wearing off. Sudden or unpredictable offs. So this is something that, we don't fully understand. Sometimes it is triggered by food competing with absorption of the medicine in your system. But that is a symptom that can happen in middle and advanced stages of Parkinson's, where the medicine just drops out of your system on you. Delayed ons, similarly, you take your medicine, you're expecting it to kick in after 30 minutes, and it doesn't. It may have a delayed on effect. Dose failures, that means you take your medicine, you're expecting it to take effect after 30 minutes, and it doesn't kick in at all. Dyskinesias, I think many people with advanced Parkinson's are familiar with this symptom, either because they've experienced it or because they've seen it in the media or read about it. But that would be wiggling movements, dance-like movements that are a side effect of our dopaminergic medications. So when these symptoms develop in advanced Parkinson's, oftentimes we change our approach to medication when this happens. And so this is what we'll go through in a later slide. But essentially what we tend to do is have you take your medicine more often. Moving on to our non-motor symptoms. So psychiatric symptoms I mentioned earlier. So these largely include anxiety, depression, psychosis. So psychosis is a major symptom that can occur in advanced Parkinson's disease, where people experience hallucinations, often seeing small children, small animals, maybe bugs, shadows in the corner of their eye, sometimes more complex matters such as, somebody's on the porch, someone's trying to come into the house. They can be quite threatening and quite disturbing as time goes on. Cognitive disorders. So people with advanced Parkinson's can develop cognitive impairment or dementia. The distinction there is, the degree to which it interacts with interferes with a person's, day-to-day life and how much help they need as a result. In Parkinson's, people tend to develop problems with multitasking, concentration, planning, and sometimes uncued memory. So it's in there, but it's hard for people to recall on their own without cueing what they were trying to, obtain at the store, something like that. Autonomic disturbances, here we're talking about the automatic functions of the body. So in advanced Parkinson's, or even in earlier stages of Parkinson's, depending on the person, because everyone's course with Parkinson's is different, as we discussed, the automatic functions can be affected. So blood pressure regulation is a really problematic one. So what we expect, when we stand up is that our blood vessels will constrict so that the blood travels from our legs, where it's pooled while we were sitting or laying, back up to our heart so it can be pumped up to our brain so that we can think and function. But what can happen in the case of autonomic disturbances is that just doesn't happen. So we stand, our blood pressure drops, we feel lightheaded, we feel dizzy, we feel woozy. That's a problem in its own right, but it's relevant because Parkinson's motor medications, the dopamine medicines, can make this problem worse. Bladder dysfunction, in the sense of maybe urgency, difficulty controlling our bladder function, can be symptoms of advanced Parkinson's. And then bowel. Primarily here, we're talking constipation, which can get quite bad in advanced Parkinson's. So what happens here in advanced Parkinson's with some of the non-motor symptoms that we talked about is that we get into a tug of war. And so here, and I like this little cartoon, we have an elephant on the left, say that's our motor symptoms of Parkinson's. And you start with Parkinson's, you're living with the disease for many years. That elephant is those motor symptoms: tremor, stiffness, slow movements, shuffling gait. You're dealing with those, and then all of a sudden, something's pulling back, we're fighting. So now we have a hippo here who's fighting with the elephant. Our motor and non-motor symptoms, our medications that treat our motor symptoms, are worsening our non-motor symptoms. So primarily what we see is that the dopaminergic medications that can help the motor symptoms in Parkinson's, that stiffness, slowness, tremors, can worsen or cause non-motor symptoms that may have already been there or may be purely medicine side effects. So the amount of medicine that I might need to treat my tremor may cause me to experience drops in blood pressure, passing out. It may cause me to hallucinate. And of course, this is a major issue. So treatment problem summarized. So in early Parkinson's, symptoms that are dopamine responsive tend to predominate. That's a pretty easy situation because we give dopamine replacement and a person can live close to a normal life. Side effects can happen, but they don't tend to be predominant. In advanced Parkinson's, however, patients are more likely to have symptoms that are either not dopamine responsive, so balance changes, falls, or symptoms that can be made worse by dopamine, such as psychosis or uh, orthostatic hypotension, which is the drop in blood pressure that I mentioned. So what do we do? So for many of the problems that I mentioned earlier, we do have some solutions that we can employ with regard to our medications to try to help these problems that come up. So if a person is having motor fluctuations or complications where their dopamine medicines are wearing off, there are things we can do. So what we can do is we can shift the timing of medication. So if maybe you take your dose 3 times a day, but it wears off an hour or two before your next dose is due, we can space the medication doses closer together to try to avoid that wearing off. We can try strategies to avoid sudden offs or delayed on states by maybe having you adjust the timing of your meals so that protein isn't interfering with your medicine kicking in or causing it to wear off. We can sometimes have our patients employ strategies to try to get their medication to kick in faster, such as taking the medication with something acidic or chewing their medication. So that's one way that we can combat some of the wearing off or fluctuations. Something else that we can do when patients are experiencing wearing off or the peak dose side effects like dyskinesias is we say, okay, well, this medication is working, but at some points in the day, it's too strong. So we can reduce the amount that you take with each dose. So a smaller number of pills taken more often so that we try to have more of a steady state with less peaks and less valleys. Sometimes what we do if a person is on medications which we know are more likely than carbidopa levodopa to cause side effects, we can shift your regimen to a purely carbidopa levodopa regimen. And so medications that may have a side effect profile that's less favorable in people with advanced Parkinson's could be medications like amantadine or artane, trihexyphenidyl, some of the dopamine agonists, things like that. So sometimes shifting towards a simpler regimen, which just includes carbidopa levodopa, is a strategy that can be used. That's favorable in other ways as well because we have a lot of adjustability with this medication and because it's widely available. So in some patients with Parkinson's in an advanced stage, we do worry about, what would happen if you go to the hospital. Is the medication that you need going to be available to you in that healthcare setting? And we do know that carbidopa levodopa is widely available, so there should be absolutely no issue with you being able to get the medication that you need. So what if those strategies don't work? So we have you on, what we think is the best regimen for you. We have, reduced the strength. We have you dosing more often, and you still have side effects. Maybe you're still hallucinating despite the fact that we made those changes, or you're still passing out despite the fact that we made those changes. That's not good. So what can we do here? So maybe we say these non-motor symptoms are more important right now. And so even though we know that if we reduce the dose of dopaminergic medications, the motor symptoms will get a bit worse, maybe it's worth it. Maybe the balance falls in that favor. So sometimes we reduce the overall dose at the expense of motor control. And then finally, sometimes we say, well, this tug of war is going to get more intense and we're going to add some animals to the mix. So maybe we add some medications to combat the side effects. So we have problematic motor symptoms, we have problematic non-motor symptoms. Maybe we add a second medicine for the non-motor symptoms so that the person can tolerate the amount of dopamine that they need. So what might that look like? Well, if I'm hallucinating, then maybe I'll add an antipsychotic medication to try to combat the hallucinations so that I can keep taking my Sinemet. Or if my blood pressure is low, despite the amount of medication that I need for my tremor, then maybe I'll add a medication to raise up my blood pressure. So as you are aware, this can get quite complicated. So sometimes that is just not an ideal strategy for someone. Sometimes none of that is satisfactory. So sometimes what we do is we hit that stage in Parkinson's and we take a moment to reflect, reframe, and rethink our approach to care for this individual person. So in early Parkinson's, our goal is to maintain motor symptoms in the early stages through medication and lifestyle. So that's what you saw in the video. What we want to do is adjust your medicines so that you are as close to normal as you can be. But in advanced Parkinson's, by definition, we're not in the early stages. Medication effects vary, and lifestyle changes may or may not be possible or effective. As you can imagine, if you're wheelchair bound, you can't exercise 30 minutes 5 times a week like we have encouraged you to do in the earlier stages of your Parkinson's. Lifestyle interventions may not have the same bang for the buck as they used to. So what we want to do is really kind of recognize the difference, not to take away your hope, but to acknowledge, that a person's experience with the disease is changing. Their life is becoming more affected by their Parkinson's. Their loved ones are more affected by Parkinson's. And very likely a person may be suffering in these advanced stages of Parkinson's. So we want to acknowledge that. There are things we can offer apart from medications to make it easier to live with advanced stages of PD. And so what might that look like? So a holistic approach to care. I like this quote here. So we cannot avoid suffering, but we can choose how to cope with it, find meaning in it, and move forward with renewed purpose. And so how do we do that? It really takes a lot of reframing because, so much of your time living with Parkinson's, is spent with doctor's visits, focusing on your motor symptoms, your non-motor symptoms. How are you taking your medicine? Bring me a log of your blood pressure. So this is a totally major shift in thinking. So how do we do it? It's not easy. Patients, families, doctors don't have a lot of training in this area, but this is kind of an emerging concept in treatment for Parkinson's and other neurological and non-neurological diseases. I put some questions on the screen to try to give you a sense of what that reframing might look like. So instead of asking the question about, what time are you taking your first dose of Sinemet for the day, we might say, how is Parkinson's affecting your life and your loved ones these days? How are you coping with this? What are your biggest concerns right now? What are your biggest concerns in the long term? These may be physical concerns, maybe emotional concerns. They may be social, mental, or spiritual concerns. What gives your life meaning? What makes you happy and what brings you joy? Where do you find strength in difficult situations? So these are just some examples of questions we might ask in the advanced stages of Parkinson's to try to reframe, refocus, kind of hone in on the big picture and how we can help the whole person, the family unit, and offer supportive care. So supportive care really goes by different names. So you may have heard of the concept of palliative care, supportive care, comfort care. Really what this means is we're employing more resources and we're treating more aspects of the person. So this may include things like complementary and alternative medicine for mental, physical, emotional, spiritual practices to reduce stress or increase resilience in order to improve quality of life in people who are suffering with advanced illness, providing more support or focusing more on support for psychosocial issues, providing care partner support or family support for the patient and caregiver unit, and then providing referrals to palliative care specialists or to hospice care specialists when a patient has greater needs than what can be accomplished in the movement disorders clinic. So this supportive care model is something, that we have available to a certain extent at the Fixell Institute, but I'm excited to share that it's also becoming an initiative of the Parkinson's Foundation. So in the coming year or two, it's going to become standard of care for all centers of excellence for Parkinson's disease to start employing supportive care and palliative care type practices for all patients with Parkinson's. And so my hope is that not only can patients partner with their doctors to kind of shift care when it's appropriate in the course of their Parkinson's disease, but that we can also have these additional resources, including caregiver and care partner support for psychosocial issues, as well as training for our own physicians on how to better support our patients through advanced stages of Parkinson's. So with that, I will close my talk. And I'm going to open the Q&A just to see if there are any questions that I might be able to answer before we start the formal Ask the Doctors or Ask the Healthcare Providers Q&A. Okay, so I see two questions in the chat that are relevant to what we discussed in this advanced PD talk. So one says, how important is it for a PD patient to see a psychologist or psychiatrist to assess their psychological health, even though that patient is not asking for an assessment? So this is an excellent question. So as we discussed, psychological symptoms of Parkinson's, including depression, anxiety, psychosis, can be prominent in Parkinson's. And it's more prominent in advanced Parkinson's, but it can occur really at any point in Parkinson's disease. Oftentimes, apathy is part of that process, and that means a person with Parkinson's may not really have a motivation to address a particular symptom. They may not be particularly bothered. And depending on the degree of their symptoms, it may be really important for a care partner or a neurologist to help the patient seek care that might impact their quality of life for the better. So the answer to that is it kind of depends. It's likely that that would be beneficial, but it depends on the situation. There is a question that says, are the Fixell Institute neurologists practicing the supportive care model now? So each neurologist at our Fixell Institute has some experience in supportive care. We will each be getting additional training in supportive care and palliative care through the training that is to be provided through the Parkinson Foundation on a national level. So that's exciting. Each neurologist treats their individual patient according to what they think is best for them. So we do try to offer supportive care in any scenario where we think it's appropriate. One of the difficulties is that it's not like a person with Parkinson's wakes up one day and suddenly has advanced Parkinson's and suddenly would benefit greatly from additional supportive care. So it's a little bit difficult sometimes for your neurologist to recognize exactly when is the right time to employ different strategies to care for your Parkinson's. And so I want to make everyone aware of that, because a lot of times people think, well, my doctor would, when my doctor thinks it's time for a change, they'll tell me. And that is true, but I think it's also helpful to be empowered with this knowledge that there is sometimes a change in treatment that's out there and available. And you could also be the impetus for change. So if you see, gosh, I'm taking medication, every hour and I'm just not getting the same bang for my buck, what am I doing here? I don't think this is helping. And you have that power to bring it up to your neurologist at your appointment. Is this, I understand the change you're suggesting. How likely is this to help me? Is this going to make a big difference or a small difference? What are the side effects? And kind of weigh the risks and benefits with your individual physician. But in short, yes, our neurologists are practicing with a supportive care model in mind, but there are some centers across the country who have a more protocol-driven process that they follow to identify patients who would benefit, and they may have more members on their team who spend more of their time working in a supportive care clinic. So we have partially a supportive care model. I have another question here, which is, what is the training of a palliative care specialist? So typically a palliative care specialist spends 1 year doing a fellowship in palliative medicine. And so that fellowship would happen at the end of their other training. So for a neurologist, they could be a palliative care specialist. What they would do is medical school, then neurology residency training, then a palliative care fellowship where they would spend a year learning how to specialize in that disorder. There are very few palliative care specialists across the country. At UF Health, we have one palliative care neurologist, and he practices primarily in the inpatient setting. So he's spends only a small amount of time in clinic and primarily works in the hospital. The goal of the palliative care program through the Parkinson's Foundation is giving movement disorders neurologists, of which there are a higher number, the skills that they need to provide palliative care directly to patients who they're already seeing, who are already in front of them in the clinic. So that way, we don't have to try to train thousands of more palliative care specialists. We can use the resource and tools that we have to provide higher quality of care for advanced Parkinson's.